Hello friends, today we are going to discuss the management of hypercapnia. So we have this patient who was 66-year-old male patient, known case of hypertension, diabetes mellitus, COPD. He was admitted in our hospital with the chief complaint of fever, breathing difficulty, and he was diagnosed with H1N1 ARDS. And initially, this patient was managed with NIV, high flow nasal cannula. So on evaluation, it was found that the patient's tropi and the proBNP was high, and he was diagnosed with the NST. After stabilization, he underwent PCR to LED. The blood culture was positive for pseudomonas, which was for which he has received the treatment. The currently patient was received avipral. So he came to our ICU after plasty, and on arrival, the patient was hemodynamically stable, and he was maintaining saturation of 85% and 5 liters of water. Initial ABG showed mixed metabolic and respiratory alkalosis. Next day, patient became drowsy. His ABG showed the type 2 respiratory failure. PCO2 was around 90 mg. So patient was intubated in view of low GCs. So chest X-ray was taken after intubation, which was suggestive of the ARDS, like picture. So patient's urine output started dropping, started him on the Lasix infusion. So next day, patient had cardiac arrest, which was lasted for 4 minutes and the reboot. So the ABG showed persistent respiratory acidosis with PaCO2 of 131 mmHg, and the patient was in refractory hypercapnia. So despite appropriate ventilatory setting, the patient's CO2 was persistently high. So we'll see now how to manage this patient. So hypercapnic acidosis was found to be the independently associated with increased mortality in various diagnostic categories of mechanically ventilated patients, including acute cerebral injury, trauma, sepsis, cardiac and respiratory, gastrointestinal and renal causes of admission to the ICU. So it appears that severe hypercapnia, especially when associated with acidosis, should be avoided or actively managed. The possible options include optimizing use of mechanical ventilation to enhance CO2 elimination. These include technique to increase minute ventilation, reduce dead space ventilation, and physiological dead space. Use of buffers such as sodium bicarbonate, tris hydroxymethyl aminomethane to correct acidosis. Use of airway pressure release ventilation, prone position ventilation, high frequency oscillation, and extracorporeal devices. Now, regarding mechanical ventilation, increasing minute ventilation. Changes in the delivery of the conventional mechanical ventilation, including optimizing the settings such as increasing respiratory rate as recommended by ARDS network may help in management of hypercapnic acidosis. Increasing respiratory rate and minute ventilation, however, involves trade-off with high minute ventilation and needing greater delivered power of mechanical ventilation. Higher mechanical power has been associated with increased risk of in-hospital mortality. Mechanical power can be measured using dynamic pressure volume curve in volume targeted ventilation mode recorded during tidal ventilation. So mechanical power can be calculated at bedside and comprises of all ventilator related variables that contribute to the ventilator induced lung injury, like tidal volume, respiratory rate, driving pressure, and airway resistance. So the increase in respiratory rate, however, is associated with dynamic hyperinflation, right ventricular dysfunction without clearance of hypertension. While increasing respiratory rate, one must be mindful of impact on other ventilatory variables, like inspiratory flow and expiratory time, as well as on mechanical power to achieve best possible balance between restoring high normocapnia and potential for ventilator-induced lung injury. Interpretation of ventilator waveform to adjust respiratory rate may aid in avoiding ventilator-associated lung injury. Now, the next intervention that we can do is reducing dead space ventilation. Dead space ventilation causes hypercapnia and was shown to be associated with increased mortality. Techniques that could reduce the dead space include alteration in ventilation circuit, and strategies to reduce physiological dead space are relatively simple to implement in patients with hypercapnic respiratory failure. Catheter mounts are routinely used to connect YPs to endotracheal tube, mainly to prevent accidental extubation. So, modification to ventilatory circuits, such as connecting YPs directly to endotracheal tube to reduce the dead space in ventilator circuit. Changes to the circuit in mechanical ventilation include removal of heat and moisture exchange, and using heated humidifier was also shown to reduce hypercapnia without need for increase in the need for increasing tidal volume or respiratory rate. Now, regarding the reduction in physiological dead space, end inspiratory pause prolongation was shown to increase clearance of hypercapnia in ARDS patients. By increasing end inspiratory pause prolongation from zero point 0.1 to zero point 0.7, demonstrated significant decrease in PaCO2 from 50 to 50. They showed that decreasing PaCO2 was due to reduction in physiological dead space. Diffusion of CO2 during respiration is timed. End inspiratory pause prolongation increases the time available for alveolar gas exchange of CO2 adherence, its elimination. It must, however, be noted that end inspiratory prolongation may be associated with potential adverse effects such as increasing intrinsic positive pressure, positive end expiratory pressure, and inversion of inspiration to expiration ratio that can increase mean airway pressure and cause dynamic hypertension. Lung recruitment and the PEEP titration. PEEP is aimed to maintain recruitment of lung region open during various pressures. Inspiration. Optimum PEEP reduces physiological dead space by recruiting atelectatic lung tissue, while excessive PEEP increases dead space by overdistension of the alveoli. With regional heterogeneity in disease lung, both overdistended and recruitment could happen at the same time, requiring the clinician to strike delicate balance between the two phenomena. However, deploying open lung strategy, that is the lung recruitment maneuver with the PEEP titration, intended to improve oxygenation and reduce the ventilator-induced lung injury, are shown to cause severe hypercapnia during first 24 hours of institution. The strategy of lung recruitment maneuver and PEEP titration, according to the best respiratory system compliance, was recently investigated by Cavalcanti in large multinational, multi-center randomized controlled trial. This study showed the higher 28-day and 6-month all-cause mortality in patients who was treated with lung recruitment. Higher mortality noted with lung recruitment was attributed to several factors, including changes in driving pressure, lung overdistension, breathtaking, need for neuromuscular blockage, and hemodynamic compromise. It is important to note that lung recruitment group, hypercapnia and acidosis, during first hour of randomization was observed, which was shown to be associated with higher mortality in mechanically ventilated patients. Buffers in the management of hypercapnic acidosis. The use of buffers in the management of hypercapnic acidosis remain controversial. Sodium bicarbonate and the trace hydroxymethyl aminomethane were both used in the clinical practice to buffer hypercapnic acidosis. Kellett et al. Demonstrated that the tris hydroxymethyl aminomethane in improving arterial pH and base deficit with reduction in PCO2 that could not be fully accounted for ventilation. So Weber et al. Also investigated the use of THEM in ARDS patients, where permissive hypercapnia was implemented for 2 hours, aiming for target PCO2 of 80 mmHg. In the randomized controlled trial of 12 patients with ARDS, the use of THAM buffering attenuated depression of myocardial contractility, hemodynamic alteration during rapid permissive hypercapnia institution. The ARDS network trial recommended the use of soda bicarb when pH was lower than 7.1. However, sodium bicarbonate infusion should not be administered to patients who are hypoxemic or having lactic acidosis. Some patients with severe ARDS will be hypercapnic in spite of best possible conventional ventilation. In such a patient, other modalities in addition to conventional ventilation may be required. This include APRV, prone position ventilation, high frequency oscillatory ventilation, airway pressure release ventilation. APRV entails the continuous positive pressure at high level with intermittent time cycle release to maintain alveolar recruitment and lung. Patient can breathe spontaneously independent of phase of respiration through biphasic positive pressure circuit. This allows the movement of posterior part of diaphragm, increasing the distribution of ventilation to dependent posterior lung region, improving ventilation perfusion matching as compared to the movement of anterior tedious region of diaphragm during controlled mechanical ventilation. APRV was initially described as spontaneous mode of ventilation to treat patients with acute lung injury with aim of maintaining lower airway pressure and to allow unrestricted spontaneous ventilation. There are some reports suggesting that APRV may prevent progression of acute lung injury in high-risk trauma patients. APRV was also shown to be effective in reducing CO2 as well as improving oxygenation without increasing minute ventilation in conjugation with reduction in peak and mean airway pressures. Improvement in gas exchange with APRV is related to the reduction in dead space ventilation. The use of APRV, however, is not widespread and this mode is not available in all commercially available ventilators. Furthermore, the improvement in survival with this mode of ventilation remains to be evaluated. Higher mean airway pressure and low release time reduces applicability of APRV in patients with conditions such as bronchopleural fistula, raised intracranial pressure, right ventricular dysfunction with prolonged expiratory time constant. Patients who cannot breathe spontaneously because of neuromuscular paralysis and diaphragmatic weakness do not benefit from this mode either. Regarding prone position ventilation, prone position reduces heterogeneity of ventilation of dorsal to ventral lung region as compared to supine position, increasing the homogeneity of stress on strain. By virtue of ventral de-recruitment, exceeding the dorsal recruitment or reduction in the hyperventilated ventral region, prone ventilation can result in reduction in the dead space. Indeed, prone ventilation was shown to decrease in hypercapnia in patients with ARDS, especially with those who are responder to prone position ventilation. Prone position was also shown to improve oxygenation and improve mortality. So prone position ventilation in the recruitment of previously excluded alveoli, reducing dead space ventilation. High frequency oscillation ventilation. High frequency oscillation ventilation is the ventilatory technique when using oscillatory pump breathing frequencies of 180 to 900 breath per minute that are used with very small tidal volume at constant airway pressure, potentially reducing volume trauma, decreasing anatomical dead space, and improving ventilation perfusion mismatch. High flow oscillation ventilation was used as mode of lung protective ventilation. The recent studies on adult patients with ARDS showed no significant benefit, with possible increase in mortality. It may be of benefit in the group of patients with more severe ARDS, with hypercapnia is unresponsive to conventional ventilation. The Fliseki et al. Reported the use of high flow oxygenation ventilation in patients with hypercapnic acidosis not responding to conventional ventilation. In their cohort of 26 patients, 24 patients responded to high flow oxygenation ventilation with improvement in hypercapnia and acidosis at 24 hours of initiating high flow oxygenation ventilation. It is, however, important to note that routine use of high flow oxygenation ventilation, oscillatory ventilation, was not recommended due to lack of mortality benefit and potential for harm with the use of high frequency oscillatory ventilation as compared to conventional ventilation with low tidal load. Some patients may have severe hypercapnia that could be managed with mechanical ventilation alone. In such a patient, extracorporeal CO2 removal need to be considered. Extracorporeal management of hypercapnia. ECMO provides oxygenation, ventilation, and cardiac assist. Oxygenation with membrane lung in the veno-venous ECMO is mainly dependent on the blood flow, and CO2 clearance is primarily dependent on the fresh gas flow. Clinical application of extracorporeal CO2 removal was first reported in observational study by Catinoni in uncontrolled group of the patient with severe ARDS. They reported encouraging results in patients with severe ARDS by using this technique as a strategy to rest the lungs. The survival rate of the treated patient in this study was 49%. The blood loss was significant. Subsequently, Morris et al. Conducted randomized clinical trial comparing pressure control inverse ratio ventilation and extracorporeal CO2 removal technique with patients with ARDS. However, no significant difference in survival was found between mechanically ventilated patients and those treated with extracorporeal CO2 removal. While there may be several important reasons for this, one of them may be concept of lung protective ventilation at that time was not as established as in the current practice of mechanical ventilation. The use of extracorporeal CO2 removal did not get much acceptance due to complexity, cost, and implication of intervention, including high blood flow rate, large cannula, systemic anticoagulation, and associated potential complications. More recently, the use of ECMO had gained momentum with improvement in technology, advances in intensive care practices, especially of the anticoagulation while patients were managed on extracorporeal circulation. CESAR studies incorporating such advances in equipment and clinical practice investigated the use of ECMO in ARDS patients with hypoxic and hypercapnic acidosis with respiratory failure. The result of CESAR showed that ECMO-based management protocol improved survival without severe disability. However, only a small proportion of the patients in this trial had hypercapnic acidosis, and results may not support the routine use of ECMO in patients with hypercapnic acidosis. Observational study on the use of ECMO in influenza A associated ARDS showed that ECMO was used as rescue therapy and the ICU mortality was 23%. More recently, Eolia trial investigated the efficacy of ECMO patients in ARDS and did not show any survival advantage. Now, the low flow extracorporeal CO2 removal devices. Over the last 2 decades, the several less invasive extracorporeal devices were evaluated as alternative to the ECMO support. These are less invasive, less complex devices that may be used to treat hypercapnia and acidosis that may be associated with the low tidal volume lung protective ventilation. Most of these are less invasive devices provide partial extracorporeal support where they are efficient in clearing CO2 but do not provide significant oxygenation. The cannulas used to access blood vessels are smaller and require minimal anticoagulation, similar to renal replacement therapy circuits. Some of the devices evaluated for extracorporeal CO2 removal include AV devices that are pumpless and veno-venous low flow devices that include pump to assist in extracorporeal circulation. These devices with the pump may be of low flow, that is 300 to 500 ml per minute, and high flow, that is 800 to 1000 ml per minute. Interventional lung assist is the sophisticated pumpless extracorporeal arteriovenous CO2 removal device that is driven by patient's cardiac output, therefore do not require extracorporeal pump assistance. Interventional lung assistance was shown to be effective in clearing hypercapnia when tidal volume is as low as 3 ml per kg of predicted body weight. However, the need of arterial cannulation increases morbidity with complications such as limb ischemia and arterial pseudomy. The low-flow venovenous devices such as HemoLung and the Prisma Lung appear to be more promising in being minimally invasive. Initial results, mainly from case reports and feasibility observational studies, appear encouraging. Extracorporeal CO2 removal at low rate and high rate was recently investigated in prospective multicentered international phase 2 study, that is supernova study. In this study, the investigator aimed to facilitate ultra-protective ventilation, that is tidal volume of 4 ml per kg of body weight and plateau pressure of 425 centimeter of water in 95 patients with moderate ARDS. The result of this study showed that ultra-protective ventilation was achieved within the 8 hours of instituting ECOG in 72 hours and 82% patient within 24 hours. This result suggests the ECOG could facilitate ultra-protective ventilation, avoiding severe hypercapnia in majority of patients. Randomized control trial are currently ongoing, that is REST trial, to further define the efficacy of these low-flow venovenous extracorporeal CO2 devices in instituting ultra-protective lung ventilation that may lead to reduction in mortality. Thank you, guys.